I'm going to try and cover a variety of topics during the course of this talk. But the thing that is clear to me is that we have more old people than young people in this country at the moment. And that plays into our national finances in the sense that younger people tend to pay the taxes and older people require support from taxes. And also, as a consequence, it plays into the funding of our National Health Service. And it's often said that if the economy sneezes, the NHS catches a cold. And so I'm kind of glad to see so many young people in the audience today and so many young people who are taking part in the FMLN. Because the present, in a sense, at the moment, belongs to the old, but the future belongs to the young. And we can't build a future without the influence of young people working in the health service. And it's a truism, I think, to say that only those people who work in the health service can actually change it. There are plenty of people outside who can commentate on it, but only those working in it can really change it. And that's played into some of our deliberations in leadership in the NHS over the last few years. In 2010, when we were thinking about setting up the FMLN, I was particularly keen that it should be set up under the jurisdiction of the Medical Royal Colleges, largely because the predecessor organisation had been the British Association of Medical Managers, and you had to kind of be a medical manager to join, and that didn't seem to make much sense. And Neil Douglas was president of the Academy of Medical Royal Colleges at the time, and he thankfully agreed for the Academy and other colleges to take it on. A year later, we set up the National Medical Directors Clinical Fellowship Program, which followed on from what was a clinical advisor program that was already in existence in the Department of Health. And I think that has led to a lot of influence in some of the policy that you've seen coming out of the Department of Health and out of NHS England. But from a personal point of view, I've been extremely impressed by the caliber of individuals that A, have applied for the positions, and B, particularly who have accepted those positions. And at a personal level, they have been tremendously supportive and helpful to me, particularly in some quite difficult times over the last few years. Another thing which came out of that program or its predecessor was the concept of agents for change. It had always seemed to me that junior doctors moved from hospital to hospital. You knew where good things were, you knew where bad things were, and yet you weren't being used for spreading good practice or for spreading knowledge of bad practice. And that just didn't seem to make any sense. So Agents for Change was born out of that. Another area which concerned me that juniors weren't getting a fair crack at the whip was when it became clear to me that some young surgeons had to give up their training post because they had set up a company. They were young entrepreneurs. And that seemed no sense at all. So subsequently, under the leadership of Tony Young, we've set up the Clinical Entrepreneur Program, which will enable people to continue with their training at the same time as developing their companies, learning about intellectual property, route to market, and things like that, and getting proper mentorship. And that will, I think, help to engage a younger generation of people in solving the problems that the NHS is facing at the moment. And finally, when I was asked, along with some other colleagues in this room, to look at the hospitals in this country that had the highest mortality, we noticed several things. We noticed that most of those hospitals were geographically isolated, but they were all academically and professionally isolated. And they didn't really know what good looked like in comparison with some of the better organizations in our NHS. And we only made 8 recommendations in that report, and one was that we needed to engage young doctors and nurses in the leadership of those organizations. Some have adopted it, some have not, but I think slowly we're starting to see a greater trend towards engaging young people in the future of the NHS. And it saddens me in a way that we're quite so far behind other industries, because when you look out at the city or big law firms or service industries, they regard the people that are in their companies between the ages of mid-20s and mid-30s as the source of their creative talent, their leadership pool. They suck people dry for their ideas, for their ambition, for their altruism. And we haven't, in my view, used the younger generation in the NHS to the extent that we should have. The other thing that I think we've been slow to recognize, compared with some other industries, is different expectations between different generations, between the baby boomers and Generation X, Y, and Z, the people born after the internet age. Different generations always have a different set of expectations. There's nothing new about that, and those expectations are defined by the time frame in which you're born. So people born in the post-war period, the baby boomers, will have a different set of expectations to people born after the advent of the internet, where information exchange is much quicker than it had been. Your expectations are formed by where you were born, the place that you were brought up. Expectations in the West are different to expectations in the East and are different to expectations in Africa. Expectations are governed by the economics of the society in which you're brought up. Between rich and poor countries, expectations are different. And expectations are also forged by the different communication channels which people associate themselves with, which in turn are generationally determined. But they're equally influenced by parenting and the society in which people are brought up. Now, you might wonder why I'm mentioning all of this. I mention it because I believe that it's important for the future of the NHS. It's important because it plays into the way that we need to structure our staffing in the NHS because of different expectations. It's important because it plays into the leadership style of the future of the NHS. And it's important because a combination of those two things means we need to continually readjust the delivery style of the NHS. Now, equally, medicine during this time will become much more complex. Public expectations for success from medical interventions is going to go up. Tolerance of mistakes will inevitably go down as science advances. And in my mind, that is why safety needs to be so high on the agenda in the NHS at the moment, and in particular a focus on human factors, which hasn't really reached the far corners of our health service as it should have at the moment. And by human factors, I mean understanding why people make mistakes, and then putting mechanisms in place that make it easy for people to do the right thing and more difficult for them to do the wrong thing in the way that other high-risk industries do, rather than simply blaming people when mistakes are made, which I think is counterproductive and the wrong way forward. Now, just returning to the present, you don't have to be an astute political commentator to recognize that we are in very difficult political times. I think it would be fair to say that these are probably the most difficult political times since the Second World War. The government is focused almost entirely on Brexit. The NHS is fairly low down the list of areas of interest, although to the public it remains a very important area. Now, there are pros and cons to having political focus on the NHS, but in any event, the message that I want to kind of make and to explore with you is that good things can come out of pretty bad political times. So if we look back to the 1940s when the NHS was founded, or we look back 70 years to 1947, things were really tricky in this country. The first 3 months saw a winter of exceptional severity, with a shortage of fuel as a consequence of the fallout from the war. In April, there were the worst floods for 53 years that affected not only this country but parts of Europe. And that affected the spring sowing, which subsequently put up the price of foodstuffs. As though that wasn't enough, in May there was an economic crisis and the exchange rate with the dollar changed, further pushing up the price of foodstuffs. And bread was rationed for the first time, having not been rationed during the war. By September, the meat ration, from which had been established during the war, was reduced. In October, the bacon ration was halved, and in November, the potatoes were rationed. So things were worse in 1947, the year before the establishment of the NHS, than they had been during the war in many ways for many families. And so my hypothesis to you is that good things can come out of really bad things. And I was on the tube the other night, it was about 11 o'clock, and I bumped into Simon Eccles, who some of you will know, an ED consultant at St. Thomas's, and he said something which I think is quite profound. He said, how bad do things have to get before we have really disruptive change and people recognize the need for significant change, not just tinkering at the edges? And I think it's worth our while as a group of clinical leaders just reflecting on that. But it's also worth reflecting on the fact that politics is fickle. It can be very difficult, but it ultimately is responsive. And when we look back at the beginning of the NHS, it was opposed by the BMA and by the Conservative government, two opposing political forces that both supported very, very strongly at the moment. And Bevan went on to describe it as the most civilized achievement of modern government, and it was at the time. But I would argue to you that a sense of complacency set in, and the NHS went very slowly into decay. And I'll come back to that in a moment. But meantime, in the 1960s, there was a small boy in Africa listening to a green and white Philips transistor radio who heard a story about the NHS, about the fact that people could get modern treatment free when they needed it without having to worry about money. And that boy was already aware of the social inequalities that existed in Central Africa at the time, and went in and subsequently spoke to his mother and asked about the National Health Service, and recognized that the health service offered a set of values that were really unique in the world, certainly in the world in which he inhabited at that particular time. And that boy said, I would like to be part of the National Health Service and train as a doctor in England as a consequence. And that small boy was me. And I still hold very, very strongly to the sense of values and everything that the NHS represents. And I think we need to be really careful that in political turmoil, when everybody's keen to point out the faults of the NHS with the best intentions in the world, because they point out the faults in the hope that we can improve them, that somehow or other we don't lose our NHS by mistake, or through inaction, or through inability to modify the way we deliver our services to meet the expectations of the public. By the time I became a consultant, first at the Hammersmith Hospital and then subsequently in Birmingham, the proportion of our gross domestic product, which was reflected in healthcare, had fallen below the European average, and waiting lists had gone up. For the younger people in the audience, you probably won't recognize what I'm about to tell you, but I was at a conference in Philadelphia, a surgical conference, and I got introduced to some Americans. And one of them said to me, do you work for the NHS? And I said, yes. And he said, that's nice. But there was a thought bubble that he thought I couldn't see, which said, poor guy, you know, he's just a white-coated automaton who works in a Stalinist bureaucracy in concrete-clad buildings while people queue round the block in the hope of getting to the front of the queue before they're treated. And I spent some time extolling the virtues of the NHS and then flew back to Birmingham, where I was practicing as a cardiac surgeon. And in those days, and I'm going back now to around about 2000, things were very different. I'd sit in the clinic, have a consultation with a man and his wife, and as you know, it's usually the man that's got cardiovascular disease, and we'd have a conversation about the pros and cons of surgery, the alternatives and all that kind of stuff, and run through the risks and benefits. And I would say to the man, any questions? He'd say no, and I'd turn to his wife and say, any questions? And she would say, when? And I would say, 18 months to 2 years. And her eyes would cloud over with tears. This look of terror would descend on her face, and she would say, we saw the GP. We waited 6 months to see the cardiologist. We waited another 6 months for the angiogram. We waited 3 months to see you, and now you're telling us it's going to be another 18 months to 2 years. And I always felt the emotion of that kind of conversation, but I defended it in my own mind by thinking, well, at least when the person gets to have the operation, the technical results will be as good as you get anywhere. And it wasn't until I really realized, I think, that as a consultant, as somebody in the health service, that I had as much role in changing the health service, addressing the waiting list issues, and addressing the way we delivered our services. It wasn't until I realized that I realized the importance, really, of clinical leadership and the way that things could be changed. But there were other things that were going on that helped me become engaged in that, and I hope that those opportunities still prevail for the people in this audience. The first was that the Blair government had become obsessed with the waiting time that patients were having, particularly in cardiac surgery, because there were stories of people dying on the waiting list. And they set about trying to increase the budget of the National Health Service so that the proportion of GDP spent on health met the European average. And a lot of that was down largely to the special advisor in health at number 10 at the time, who was Simon Stevens. And the budget of the health service was significantly increased. But it came with conditions. It came with conditions that certain issues needed to be addressed, not least of all waiting lists. And one of the ways of dealing with that was to engage the clinical community. And a series of programs called National Service Frameworks were developed. There was one in cardiovascular disease, one in diabetes, one in mental health, one in renal disease, one in cancer. And the idea was that you would get clinical experts in a room, you would ask them what needs to be done. That would then be costed. Someone would say, yes, we can afford it, or we couldn't afford it. It would go to the Treasury, it would come back, and an iterative cycle would take place until we ended up with a plan that was A, clinically credible, and B, financially deliverable. And that was the beginning, I think, of real clinical leadership in the NHS. Some characters who became household names in the health service were very, very powerful leaders in this. Mike Richards was National Cancer Director. Roger Boyle, the Director for Cardiovascular Disease, who in my view has done more for cardiovascular disease in this country since the inception of the NHS than anybody else. I then moved from Birmingham after the advent of the National Service Framework for Cardiovascular Disease to University College London, to the Heart Hospital. And by the time I stopped clinical practice to move into the Department of Health in 2007, it was a very different conversation with patients. We would have a man and his wife come into the room, similar sort of conversation would happen, and then the man's wife would say, when? And I would say, well, you know, next week, week after. And this time a look of abject fear would descend on their faces, and they'd say, but we thought waiting lists were long, we booked a holiday. And it was a completely different sort of conversation to have with people, because you could spend much more of your time focusing on what really bothered them, which was the nature of the disease and the nature of the treatment, not the nature of when am I going to actually get some treatment. So at the end of 2007, I was appointed medical director for the National Health Service in the Department of Health. And at that time, I think it was fair to say that the NHS was improving quite considerably. We were making progress on the diseases which I've mentioned: mental health, diabetes, cardiovascular disease, cancer. We were approaching the 60th anniversary of the NHS, and Aradazi, who was then Professor of Surgery at Imperial College, had been brought in as Minister in the Lords to lead a review of the National Health Service. And he did that by engaging 60,000 people working around the National Health Service, asking them what we needed to do. And to cut a long story short, he published a review in 2008, but to my mind, there were kind of three findings in that review. The first was that we had dropped the ball on quality while focusing on money. The second was that clinical leaders and managerial leaders were in different places, and that we didn't have adequately influential clinical leadership in the National Health Service, and that we weren't focusing on personalization. And by personalization, in that context, he meant a spectrum which ranged at one end of the spectrum from treating people decently who came into your clinic, standing up, shaking hands, offering them the courtesies you might offer someone who you didn't know coming into your own home, right through to pharmacogenetics at the other end. And one of the things I've learned in this job is that personalization means something completely different to everybody you speak to. But one of the interesting things that came out of the focus on quality was, how do you define quality? At that time, Bill Kirkup, who led the Morecambe Bay investigation, was my deputy, and his mum was about to undergo coronary surgery. And she asked him three questions. She asked him, is it going to be any good? Is it safe? And what's it going to be like? And that ended up on a focus that we would define quality within the three domains of clinical effectiveness, safety, and patient experience. And that had the advantage that you can measure each of those three domains in some way or another. And it also has salience for people who are offering services at a personal level. Because ultimately, the NHS is simply an aggregate of interactions which happen on a daily basis, of one person who is feeling frightened, in pain, or unwell, seeking help in a private encounter with somebody else working for the NHS who can help them. And everything that surrounds that, whether it's the real estate, the IT, other bits of infrastructure, the HR processes, they are all there simply to make sure that that encounter is a good one for the patient. And at times, I think parts of the NHS forget that that is the fundamental business that we're in. Now, so we seem to be making quite good progress. The end of 2007, the beginning of 2008, and then the global financial crisis hit. And that has led, in my view, probably to the most difficult 10 years in the history of the NHS. I might say that simply because I've been close to it. There may be others who take a different view, but it has certainly been tricky, because it immediately became apparent that the government had two approaches to dealing with the global financial crisis. One was to invest money into infrastructure and create jobs that way. The other was to reduce public expenditure, let the private sector and entrepreneurs and others step in to create jobs whilst public spending was reduced. In other words, the so-called austerity measures. And that was the approach taken mainly across Western Europe. There was a bit of a stimulus package in North America. But the end result of that meant that it became clear that the amount of money that was going to be available out of the public exchequer for the NHS was going to remain relatively constant for the foreseeable future. And that was against a background of annual increases in public expenditure for the health service being somewhere between 4 and 5%, with ups and downs since the inception of the NHS. But during the period that the proportion of GDP was being increased, increases in money of almost 9% per year. So we suddenly went from having money being injected into the National Health Service to the very real threat that there wasn't going to be much for the foreseeable future, and that turned out to be true. So the first thing we needed to do was think about what that meant, and we knew that demand was increasing at about 4% per year. We knew we had a budget of £100 billion, broadly speaking, and over the period of 5 years, that meant that if we were going to continue doing things the way we did them, we would need an extra £20 billion. But we didn't have an extra £20 billion, so we needed to find efficiency savings to enable the NHS to continue to offer the level of service that it had previously offered. And after 5 years, we met that challenge. But then it turned out that the austerity was going to continue. And we entered into another 5-year period where the amount of money that it looked like we might need to save was closer to £30 billion. And by then we'd picked all the low-hanging fruit and things started to get tough. And people such as yourselves on the front line started to really feel the draft in a way that I think other generations may not have. And that provides with it some serious opportunities for rethinking the way that we deliver our services. The answer to Simon Eccles' question about how difficult does it have to get before we redeliver things. But it does impose a set of very difficult problems. But on top of that, as though the global financial crisis wasn't enough, we had another election in 2010. A new government came in who wanted to reform the NHS further. And when I look back at those days when the reforms were being developed under Andrew Lansley as the Health Secretary, I think of the intent. And the intent in some way was slightly different to the outcome. So the intent was to improve the focus on clinical outcomes, and I'll come back to that in a second, to increase clinical leadership in the National Health Service, and to focus more on personalization. Now, if I come back to clinical outcomes, Andrew Lansley summoned me and said, I want to make clinical outcomes the currency of the NHS. Well, that seemed to me like a pretty good idea, because everywhere you go in the NHS, people say, well, if we focused on clinical outcomes and we let doctors and nurses run the place, we'd be in good shape. The question is, how do you make clinical outcomes the currency of the NHS? And one of the benefits I had at the time working in the Department of Health was surrounded by really smart people. And a guy called John Stewart, who had recently come over from the Cabinet Office, rang me about 48 hours later and he said, Bruce, he said, I think I've got it. He said, there are 5 things that any healthcare service in the world should do. He said, the first is, it should stop you dying prematurely, recognizing that most of the determinants of premature mortality in society lie outside the jurisdiction of the NHS. They lie in education, tobacco usage, housing, transport policies. But there are certain things the NHS can do. It can stop you dying prematurely from stroke, heart attacks, and other diseases. The second thing it should do is that it should help you live well if you have a long-term condition, whatever that happens to be. Asthma, rheumatoid arthritis, diabetes. The third thing it should do is it should help you recover quickly from short episodes of illness, broken leg, cataract operation, that sort of thing. The fourth thing that it should do is that it should treat you decently. It should give you as decent an experience as it can under the circumstances. And then the fifth thing it should do is it should treat you safely. And I'm quite clear about what I mean by safely. To me, that means that people accept the risk of their disease, they accept the risk of treatment, they make some kind of judgment on that. What they should never have to accept or take into consideration is that the way we deliver our services and design our services will adversely affect that risk. And that's where I think we have a real role in the NHS, because it should be clinicians designing the way we deliver our services. And I'll come back to that later on. The second thing that Andrew Lansley wanted to do was sharpen up clinical leadership. And in his mind, that meant making clinicians responsible to an increasing degree in the way the taxpayers' pound was spent. And that led to the concept of clinical commissioning groups and handing a significant proportion of the NHS budget over to clinically led clinical commissioning groups. There is an argument in my mind that there was an issue of timing in all of that, because that's a reasonable thing to do when you have plenty of money and when you have the headroom to maybe not get everything right initially. And so to do that during the time of the global financial crisis, there are two arguments to that. One is it's the perfect time to do it, and the other is it's not the perfect time to do it. And I'll leave people to form their own views. But as a consequence of both ARA's review and some of the reforms that Lansley put in place, I think we now have more medical leadership and clinical leadership than we've ever seen in the NHS. And just to give you a feel for that, and this sounds a bit structural, we have NHS England, NHS Improvement, Health Education England, all of whom have their own medical directors. NHS England and NHS Improvement have regional medical directors. NHS England has area team medical directors. We have 15 academic health science networks, which are predominantly clinically led. We have clinical senates that, as they say in the title, are clinically led. We have more NCDs than we had in the Department of Health. We have over 200 clinical commissioning groups, which are clinically led. We have the Getting It Right First Time program led by Tim Briggs, which is clinically led. And we have a clinical national quality board overseeing the NHS. So we've never had more clinical input. At times, it hasn't been as coherent as it could be, but I think it's getting there. So, coincidentally, some of those structural changes and some of that clinical leadership, in my view, is compatible with changing leadership style that we're seeing around the world in Western democracies. It seems to me that there are some shifting tectonic plates in the way that leadership happens. And we've seen that both in the way that the Brexit campaign and vote ended, and we've seen it in the way that the election in North America was conducted and ended. And it strikes me that the fundamental driving force in some of those considerations by the electorate were a deep sense of suspicion for the institutions that were meant to be looking after people, a deep suspicion that the institutions that inhabited the so-called swamps of Washington were not looking after the kind of middle-range person in North America or the poor person. Those people are becoming increasingly disillusioned and felt increasingly detached from what was happening in the institutions of government. Similarly, in this country, we saw people becoming increasingly disillusioned emotionally with the institutions of the European Union that were meant to be looking after us, and people worried about their jobs and the influences on regulations that were affecting their day-to-day lives. And you might think, well, why is he bringing that up now? Well, I bring that up because I think that starts to play into a new leadership style in the NHS. So as CCGs are formed, as we see a greater focus on localism in the NHS, we see the opportunity for much greater local leadership, which will change the relationship between the institutions of medicine and people who are doing the change out in local areas and regions. And I think that is something quite important. And I'll perhaps come back to that a little bit later. Because making change in the health service is really difficult. We are not a single national organization. We have 137 acute trusts. We have 17 specialist trusts. We have 56 mental health trusts. We have 35 community trusts. We have 10 ambulance trusts. We have 7,875 general practices. We have 853 private providers functioning on 7,331 sites. Most of those organizations have their own boards, their own ideas of how to do things. So we actually, our NHS is a conglomerate of semi-competitive, semi-autonomous organizations. But increasingly, I think we should start to see our NHS as a social movement, a movement which is based on values and the desire to help the person in the metaphorical room that is seeking help that I described earlier. And that means, as we see this movement to localism, that leadership is everybody's business. I walk into some organizations at times and I hear consultants on what might be regarded as good managerial salaries saying, "The trust are making me do this." Well, actually, everybody who's drawing a salary like that, or anybody who has the title consultant, is de facto a senior management in their organization. And we cannot abrogate responsibility and say the trust, because if you have 10 consultants showing up in a chief executive's office, you generally know which way that conversation is going to go. So we have huge influence that we don't use as effectively as we could. We're starting to see increasing influence from general practitioner colleagues, I think out in the front line now, which has been exposed by CCGs. And I find myself encountering some really very, very spectacular leaders out in primary care who I think over the course of the next few years will make a very, very significant difference to our National Health Service. But we have 4 particular drivers, in my view, that are going to change all healthcare systems around the world. The first, and numero uno, is economics. Economics will determine how healthcare systems are run. And whilst it's easy for us to say we need more money, there clearly isn't enough money in the United States to deliver the healthcare system that they may or may not want. You just need to look at the debates in the Senate to see that. We don't feel we have enough money to do what we need to do. They don't have enough money in Zimbabwe to do what they need to do. An important role for us as clinical leaders is A, to ensure that the services that we offer are compatible with the amount of money that's been voted to us by Parliament, and secondly, to ensure that we put coherent arguments for the amount of money that we need. And I'm not sure we've been that good, because if we were to be given more money, how would we spend it? Would we spend it on capital? Would we spend it on staff that we don't have? Would we spend it on drugs? And clinical leaders, I think, need to form a view on that, because whoever you speak to gives something slightly different. And that is one of the issues that having the kind of leadership we've got at the moment that we can tackle. I think we're in a much better position now than we were a decade ago. The second area that is going to influence healthcare is science and technology, of which information technology is going to be the major determinant, simply because it'll bring immediacy of access to information, and it will slowly transform medicine into a knowledge transfer business. in the way that other industries have gone. Some of you will remember the days when if you wanted to book a holiday, you went down somewhere on a Saturday, you waited for the travel agent to open at 9, you looked at some brochures, they then asked you to come and sit in a chair, you looked at the back of a computer while somebody else typed in some opaque instructions into the computer and said you can go to A, B, C, or D, and then you went home and a few days later some tickets arrived in the post. A bit like booking a hospital appointment. But, you know, the reality is we don't expect that in other aspects of our lives where we run our social lives, financial lives, travel lives, retail lives online. And health has to catch up, and the younger generation will expect it to catch up. And soon, the big purveyors of knowledge transfer, the Googles, the Apples of this world, will be getting into this business, and we need to be ready. And the regulators need to be ready, because I believe there's a gap opening up between the possibilities and the regulatory environment. And then there are a set of expectations. In all countries, politicians expect value for money, and they expect high-quality care. Patients expect value for money and high-quality care. And corporates expect to get a reasonable rate of return on their investment into healthcare. And then there's demographics. And we're seeing, I've already alluded to the fact we have more old people than young people. And you perhaps wonder why I put demographics last. And one of the reasons I put demographics last is not to minimize it, but in a sense, if we had unlimited money, we could probably deal with most of the demographic changes without too much difficulty. So we have a number of issues that we have to face. But I put it to you, we've got form. We've got form for solving some really, really difficult problems. If I look back over the last 10 to 15 years, I remember sitting in my office when some directive from the Department of Health came through. I was in Birmingham at the time. And it said, we've got to reduce MRSA by 50% over 3 years or something like that. And that directive had come from a Secretary of State, John Reed, who had become fed up with the Daily Mail always running stories on MRSA. So he summoned the chief nursing officer in and said, do something about it, halve it in 3 years. And I remember just saying to my secretary, why doesn't he just visit our ITU, look at the old people who are sick, immunosuppressed, heart transplant or lung transplant patients? You know, MRSA is the kind of price you pay for dealing with much sicker patients. And then in 2007-8, if my memory serves me correctly, the number of MRSA infections, blood-borne MRSA infections, about 7,700 per year. By 2013-14, it had gone down to 817, an almost 90% reduction. And you know, sometimes in this business, it's really good to be wrong. But the MRSA was tackled by us doing what we knew needed to be done. But what really niggles at me is that the ambition came from a politician, not from within the medical profession. The other area where we've shown remarkable improvements is in trauma. We knew that we were falling behind in our trauma services compared with the rest of the world. Under the leadership of Keith Willett, we introduced 27 trauma centers, 22 networks, and that meant that some ambulances would travel past 1 or 2 A&Es with people who had been involved in trauma to take them to a trauma center. Well-known newspapers said it was a scandal, it was cost-saving, people would die in the backs of ambulances, and what were we up to? And in the first year of operation, people with the highest levels of injury severity scores, their odds ratio of survival went up 15%. In the second year, they went up 30%, and in the third year, they went up 50%. That was good for our patients, and furthermore, the variation in clinical outcomes reduced between units. Secondly, with stroke, we developed a stroke strategy under the leadership of Roger Boyle, and as part of the introduction of that in London, the number of admitting centres for stroke was reduced from 32 to 8. Again, The same commentators, it's a scandal, it's just to save money. People are going to die in the ambulances, what are you doing? Well, by focusing on developing hyperacute stroke units and offering thrombolysis and ensuring that people got proper stroke care, in relatively short order, they were able to demonstrate in London a reduced mortality for stroke, a reduced length of stay, a greater return to independent living, and tens of millions of pounds saved for reinvestment in the NHS in other areas that needed the same attention. Similarly, with hip fractures, the treatment of hip fractures has been completely transformed, again under the leadership of Keith Willett, with now more than 90% of patients receiving 9 out of 10 specific parts of the care bundle that's defined in the best practice tariff. I don't think there's any other country in the world that can demonstrate the level of improvement that we have seen in hip fractures. Similarly, with ST elevation, myocardial infarction, serious heart attacks, 99% of people in this country are now getting primary angioplasty, and they're getting it in a time frame that is absolutely spectacular. I think the median door to balloon times around about 40 minutes. I don't want to quote the exact figure because it doesn't spring to mind. But we're also seeing that patients, when they're discharged after a heart attack, we have very, very high rates of people being on the right medications. This is something that in our NHS we should be truly proud of. Similarly, the diagnosis of people with dementia, against some controversy, we've increased the dementia diagnosis rate from about 40% of people in the population to around about 70%. Not everybody liked that on the basis that we couldn't offer real medicalized treatment to people with dementia. But what we have been able to offer them is structured support through various services. And that has been of enormous benefit to many families around the country. But one of the things that I think I learnt the most from was from venous thromboembolism. So I went to an all-party parliamentary group, must have been around 2009-10, and I was presented with evidence that lots of people in our hospitals were dying from venous thromboembolism. The sorts of figures which were quoted were very high and probably wouldn't stand up to scrutiny, but it was postulated that about 38,000 people had VTE of some form or another in our hospitals, and about 25,000 people were dying, and that many of those were avoidable. And as the evidence was presented, what became clear to me was that the researchers weren't really arguing. And when we got to the end of the various presentations, the president of the Royal College of Surgeons, John Black, stood up and he said, look, he said, I did my thesis on this 30 years ago. He said, and nothing's changed. Why don't you mandate venous thromboembolism prophylaxis in the NHS? And then he sat down. And then the president of the Royal College of Physicians stood up and said, yeah, why don't you? And I was kind of taken aback. And I gave some wishy-washy answer about, well, it's not for me to tell clinicians what to do. It's, for others who know more about this, for individual clinicians to determine what they're going to do. And that was what I thought was a fair answer until I was walking back to my office. And suddenly it dawned on me that they weren't asking me to tell them what they needed to do. They were asking me to make it easier for people to do what they know they needed to do. And once that penny dropped, I met with the 10 Strategic Health Authority medical directors, some of whom are in this room. Peter Lees is one of them. And we thought, is this something worth tackling? There had never been a major clinical priority for the NHS before. And we thought, yes, okay, we'll focus on this. So then we met with the presidents of all the Royal Colleges. And within minutes, it was agreed that this was the right thing to do. And then the question was, who should do what in terms of making a change in the NHS? And it became clear that the institutions of medicine, the colleges, the specialist associations, who were trusted by their members, could most effectively do the communication, because no one would either believe or read anything that came out of the Department of Health or the equivalent bodies, but they would believe what their colleges told them, and that the role of those of us who worked in the system, the SHA medical directors, myself, and the NHS Management Board, could put financial incentives in place and other incentives to make organizations help clinicians do what needed to be done. And over the course of about 18 months, we went up from assessment of venous thromboembolism risk from around about 40%. We weren't entirely clear what it was. We knew it wasn't higher than that, up to over 90% and climbing. And in parallel with that, an increasing number of people getting the right sort of prophylactic treatment. And I learned a lot from that. I learned that if you leave the communication to the colleges and others, and you let the clinicians lead the way something could be done, and simply use NHS management structures to support that, you could affect great change. And I think that was one of the fastest changes we've ever seen. And it was the first clinical priority. One of the areas that we're keen to focus on now is on sepsis. And you will start to see that rise up the agenda, because it's clearly something that affects the lives of people on the front line. It's a devastating condition. It's difficult to diagnose, and then when you do diagnose it, sometimes it's too late, and then sometimes the way things are organized makes it difficult to make the diagnosis. You know, you don't have the blood culture bottles, or the things are in the wrong place. And then when you do make the diagnosis, it's difficult to treat on time. And we have a number of solutions which are being put in place at the moment. But in 2015, when we first put in some financial incentives to try and encourage this, the proportion of people in emergency departments who were assessed for sepsis went up from 52% to 78%, and the people getting antibiotics in a timely fashion went up from just under 50 to over 60%. So where we have common cause and a good clinical will to do stuff, it is possible for the managerial constructs to be put in place to help that. And the linkage in all of that, in my mind, is what I call common cause clinical leadership. And that's something that organizations like the FMLN can help on in an extraordinarily powerful way, in my view. But I'd like to leave you with a thought that I still believe that our NHS can be the best healthcare system in the world. I believe it's a stone's throw away, and people have heard me say there will be massive arguments about the size of the stone, the weight of the stone, who's going to throw the stone and how far is it going to go. But I still think we have the right substrate. And there are things that make me say that. If you look at the contribution of our country to science and technology, it's absolutely fantastic. So in science, we discovered the vaccination for smallpox, Jenner, said to have saved more lives than have been lost in all the wars humankind has ever fought. We discovered the theory of evolution. We introduced antisepsis with Lister. We've unraveled the double helix. We hold most of the intellectual property behind nucleic acid chemistry for that. We discovered the first antibiotics. In my business, we discovered the ability to stop and start the heart electively. We did the first cloning of a mammal in Dolly the sheep. We invented in vitro fertilization in a district general hospital. We did the first blood transfusion, the first stem cell transplant. I mean, that is a major contribution to global medicine. As though that's not enough, we invented the clinical thermometer, the intraocular lens, the artificial hip, the laryngeal mask, the MRI scanner, the CT scanner. So we have form for innovation and invention. We have 4 of the top 10 universities in the world. We have 1% of the world's population. We do 3% of the world's research. We produce 6% of the world's medical research papers and 16% of the highest cited papers. That's a big contribution. As a consequence of all of that, we have twice as many Nobel Prize winners for medicine or physiology per capita of population than the United States. We rank number 2 or 3 in the world's Global Innovation Index, which is put together by INSEAD and the World Intellectual Property Organization. And on top of that, we have the NHS, which is one of the greatest social innovations, I think, that the world has ever seen. And if we could couple the application of all of that science with the 440 million people we see a year in pharmacies, the 360 million we see in primary care, the 100 million we see in community services, the 100 million we see in outpatients, the 24 million we see in A&E, the 16 million people who are admitted to hospitals, or the 9 million ambulance services, we could really be innovative. We could really do good stuff. And that's what makes me think that we have the potential for the best healthcare system in the world. And so, if I come back to the politics of our NHS at the moment, I find myself asking, what would Bevan do now if he were to come back? He'd take a look and he would think, well, when the NHS was set up in 1948, the average life expectancy of a male was about 65. So half of men never got to retiring age. I'm using men because women's life expectancy is slightly longer. He would now look and he would see it's just over 80, and there's this kind of 15-year extension of life. And that 15-year extension is represented by a lot of people who are alive now that wouldn't have been alive then because we didn't have some basic therapies like anti-cancer drugs, antihypertensives, diuretics, decent antibiotics. But a lot of those people are quite elderly, septuagenarians, octogenarians, but they are all individual people. But as an aggregate, they live on a physiological spectrum, a continuous physiological spectrum between those people who at one end of the spectrum require intensive medical therapy, and at the other end of the spectrum are out walking their dogs and riding bikes. But most people sit somewhere in the middle. They require some degree of support, whether it's from their families, their communities, from social services, or from medication. And yet, right in the middle of that normal human spectrum, we have a massive fracture. We have a philosophical, bureaucratic, administrative, and financial fracture between the NHS, which has to deal with illness, and local authorities and social services who have other roles in health. The local authority is responsible for the prevention of disease in many senses through education, immunization, transport, housing policies. And they are also responsible for helping to keep people out of hospital who require some of the support that I've described but are not ill enough to be in hospital. And yet in many parts of the country, until recently, the NHS and local authorities function completely independently. So he might say, now is time for a proper health and social care system. And he might say that that is best done locally, and it is best started by getting the leaders of the NHS and the local authorities in the same room together. He might even say that that is the key to sustainability and transformation in the NHS. He might even call them sustainability and transformation partnerships. But in any event, the point is quite simple. We can no longer run a system where the NHS and other services function independently of each other. But it will raise some tensions. As we go to increased local leadership, it'll raise tensions about variation. It'll raise issues about local control versus central control, probably manifest through things like orthopedics or in vitro fertilization. It'll raise questions about how much money do you put into prevention or into acute care, about how much do you collaborate and how much do you compete. In my view, collaboration is the key to this, and any competition that happens should be based almost entirely on getting the best clinical outcomes. It will raise issues about how we maintain twin tracks between old people who want care close to home and continuity of care, and young people who want immediacy of access to treatment. And it will raise tensions as the money gets tight between clinicians and managers. And one of the great things about the outcomes framework, which focused on clinical outcomes, it meant everybody was focused on the same goals. So I put it to you that there are a lot of opportunities out there for us. There are new technologies which are going to come in from the blind side, which we need to be alert to, which some of our clinical entrepreneurs are working on, which will have a major impact on healthcare. And the three of those I would single out are mobile technology, artificial intelligence, and genomics. And we lead the world in genomics by about five years at the moment. So, there is one paradox which is worthy of consideration. In the early 1950s, Nye Bevan wrote a book called In Place of Fear, where he made the arguments for the National Health Service. He described all the arguments he'd been through. And the title In Place of Fear was simply to encapsulate the fundamental principle that people should be able to get good health care without having to worry about whether they could afford it or not. That book is still available on Amazon. It addresses every political point that you hear on the radio even this week, and it does so in quaint 1950s English. It's worth reading. But the thing is that after the war, people were frightened of the past. They were frightened of what they had been through. They didn't want to go back to having to pay for medical care, which meant they were not frightened of the future. The paradox we have at the moment is that public satisfaction with the NHS is about as high as it's ever been. So people are content with what they have, which means that they are frightened of some of the changes that many of us feel need to happen. And that's changes locally and changes nationally. So one of the things that we can offer as clinical leaders to our citizens, to our politicians, is a very clear narrative, and this is probably best affected locally, particularly in reconfigurations. A very clear narrative about what the proposals are when there is change, and a clear vision as to how those proposals offer a solution that is better than the present. I was speaking in Ireland to a group of people, and a guy who was in his 90s sat in the front row, and he put his hand up, and he was a surgeon, and he said, I'm on the board of the Bank of Ireland at the moment. He said, they're not worried about change. He said, they fear loss. So in any narrative we put, we need to ensure that we assuage people's fear of loss. And it's interesting, isn't it, that internet banking and mobile banking was taken up in North Africa far quicker than it was taken up in Europe. The reason being that people had no realistic alternative. There weren't banks littering the Serengeti plain, but your mobile phone could get you to a bank. And I think there are great opportunities for us in the NHS to take up some of these technologies as they come. So I put it to you that we live in pretty difficult political times for our NHS, but in many senses, the times and opportunities have never been more exciting. And the execution and the vision for that needs to come from clinical leaders of all ages in our National Health Service. Thanks very much.